This program is brought to you by Emory University.
Hi, good morning, everyone. Thank you for joining. It is my great pleasure. This is actually our last Grand Rounds of the year, last but not least. It is my great pleasure to introduce Dr. Amit Shah, who is presenting the Grand Rounds today on applications of digital health technology and CV prevention. Many of you know Amit, and you have probably worked with him, because I feel like everybody at some point ends up working with Amit. Dr. Shah graduated from University of Pennsylvania with medical degree, and before that he was a physics major at Princeton. So, I can see where some of his biophysics and physics background he tries to pull in to work here. Most of us don't use our undergrad, education. So he went to internal medicine. He did his internal medicine training at Albert Einstein, and then did a clinical investigator track here at Emory. He's an assistant professor, tenure track in the Department of Epidemiology, and also adjunct professor here in Division of Cardiology. Amit's also the chief of preventive cardiology at the VA and director of cardiac rehab. For those of you who know him, he has a passion for cardiac rehab and innovative methods, provides a lot of really good care to our veterans. He's received numerous awards over the years, an impressive publication record of about 135 is what I counted. But as we speak, at the end of this hour, there's probably a paper with Amit's name being published somewhere. Amit has received an R01 on PTSD and arrhythmia risk. He's been very integral to our ECRI research. He focuses on mental stress, autonomic dysfunction, and a lot of innovative things, and I look forward to this talk today. Amit?
Thank you so much, Pooja, for the warm welcome. It's an honor to be here to share some ideas and some of the work we do. And it truly is a team effort, as you can see by all the badges here on the home screen, that this is really a really nice opportunity, this research to come together, not only with Emory, but with its affiliate partners and the other hospitals, and try to create some interesting synergies. So I don't have any personal conflicts of interest to disclose, but I did want to just briefly mention some of the research grants. We are funded by a combination of public and private sponsors. So I wanted to start with the why. So why is it that we need to consider prevention with mobile health technologies? I think a lot of times we think about technology and we think of it as a problem in which there is, or more of a solution looking for a problem, but there really is a big problem. And what I want to emphasize is the most dramatic aspect of cardiovascular disease, which is unanticipated, catastrophic, sudden cardiac deaths that occur at a home setting. And it's pretty sobering to think about the fact that out of all cardiovascular disease deaths, while many of us as healthcare providers are people who see cardiovascular disease deaths occur in the hospital setting, a large percentage occur in the home setting unexpectedly before there is any real chance at intervening. An estimated 31% of cardiovascular disease deaths occur in the home setting, and this has gone up. In the last 20 years, it's increased by close to 50%. So during the pandemic, this problem is exacerbated, and in particular, there have been some interesting studies looking at out-of-hospital cardiac arrests, and these in particular have gone up during the pandemic, which is really, really concerning. I have here a graph from one of the published papers in JAMA Cardiology that looked at out-of-hospital cardiac arrests during the pandemic in New York City. And you can see here that compared to a control period, I think it was like a year before, during the pandemic, there were a significantly increased number of resuscitations. At the peak, probably the estimate was about a 10-fold increased number of resuscitations in New York City during the pandemic. And I think we could think of this as multifactorial, probably related to not only the fact that some people may have had COVID undiagnosed, perhaps, and complications from that, such as thrombosis, but also related to the other aspects of COVID, such as some of the stress and panic related to it. So I think that mHealth technology is something I would like to consider as a targeted way to think about this major concern that catastrophic illness, in particular sudden cardiac death, can occur outside of hospital walls. I am including in that, however, unplanned hospitalizations. So ultimately, we are trying to keep people out of the hospital, whether it's in our ambulatory care or in our transitions care after a hospital discharge. And mHealth technologies are very relevant there as well. We have a lot of questions in front of us. New technologies take a very long time to implement. And I think there are several dimensions to consider. How does mHealth technology improve self-care? How does it reduce barriers to care and overall improve access? How does it prevent unanticipated catastrophic events? And is it cost effective? If so, if not, how can we make it more cost effective? So overall, the winds are going in the direction of mHealth technology being something that's easier to use. Not only are more people using mHealth technologies in their personal lives, but nowadays there are more and more payment structures that make this something that is cost effective, or at least cost neutral for hospitals to provide this care with some of the transition care billing codes and remote patient monitoring billing codes. Overall, if we look at the number of people that are offline, so to speak, people that do not have access to internet, don't have a smartphone with a cellular data plan, it's really impressive to see how that number has decreased over time in a dramatic way. These data are from the Pew Research Center, and at this point, as of last year, only 7% of households were considered offline. Most of these people are people who are older, lower income, and even then, in these groups in which you would not expect, or we typically don't see in our experience even a lot of technology utilization, it's still a small minority of people that do not yet have access to the internet. And I want to particularly focus on the people 65 and older who we disproportionately see in the hospital and also die from cardiovascular disease and its complications. And we can see here that over the past 10 years or so, that smartphone ownership has gone up from 13% to 61% in 2021. So this is staggering, and you can imagine as we move forward, how this is going to continue to change over time. It will eventually hit a ceiling effect as we are seeing here for those age 18 to 29. We started off at 66%, kind of where we are with the age 65 and up, and now it's at 96%. So I think it's only a matter of time before we start to get there with everyone, especially with a lot of the digital divide policies that are being put in play. We are going to see more and more. I don't want to give a totally biased presentation if possible. I do want to present both sides of things, and I think that this is a discussion that we can and should continue to have. It does help to guide our efforts moving forward. A lot of health technology comes from the consumer, kind of type of applications or of really products. They're aimed at consumers, not so much through clinical venues. And so a lot of what we see from smart devices do not offer clinical validation. That's changing over time, especially with a lot of the FDA applications and clearances that we have seen for atrial fibrillation. But otherwise, for a lot of these things, if you look at things like steps and calories, for example, from fitness trackers, a lot of them are not FDA cleared. And FDA is still working on what their policies are with these, and they're coming out with guidance. I saw recently there's some draft guidance that they had posted online with regards to mobile health technologies. So this is still very much new as it relates to trying to grapple with what do we do with the limited evidence and what do we do in our clinical practice. Providers already, I think it's very clear that providers are already very, very busy, that clinical, especially outpatient clinics, but also on the inpatient side, that we barely have enough time to deal with the large amounts of information, even before adding in mHealth technologies. And then even so, how do we access it? I think these are really important and key questions that we need to work on and unravel. And I think that ultimately it's a ton of data as we think about what someone does every single day with their heart rate and their steps, for example, with their mobile health phones. How do we consolidate this and put it in a way that's clinically actionable? These are really, really difficult challenges for us. That being said, we have some really lofty goals in trying to make health technology, or trying to use health technology to reduce catastrophic cardiovascular disease outcomes. And I think that there are a lot of efforts, and obviously the winds are going towards making technology more accessible. There's this holy grail of really trying to offer more personalized care, and I think that health technology can offer that. But also, is it possible really to make care more efficient because we are more targeted with our approaches? Ultimately, if we can do an effective job with mobile health technologies, can we reduce utilization, meaning particularly reduce hospitalizations, and ultimately trickling down to cost? And can we improve health outcomes? I think these are some of the key goals that we're having in front of us. I do want to present sort of a very balanced approach at what this transformation is doing on the doctor-patient relationship. I think that there's a lot to be said and a lot of relevance to this personal connection to the human touch, and really being able to spend time together with people and getting to know them well. And I think that that's something that we're very good at and is, I think, really important in terms of health outcomes. This paradigm shift is something that does come with distinct advantages, however, and the question is, how can we get a balance of both? So to be able to have some really relevant, important in-person communications, but also take advantage of the detailed physiological data that can come from wearables, for example, objective data on sleep, objective data on physical activity. These are things that are really hard to measure when we're talking to people, and there's a tremendous bias, a self-report bias, for example, for people to over account for what they actually do. It could be 2 to 3 times as much in terms of what people say versus what they do if you were able to measure it objectively. So being able to get ambulatory remote patient monitoring data could provide really important critical insight. And ultimately, as we think about remote patient monitoring systems and dashboards, as we will present later, we are lowering barriers to care. So as we are with this conference right now, with many people dialing in remotely, ultimately what we do see is we see less engagement potentially, but more wider outreach, more people able to access. And so then there's a balancing act, and I think that right now we are in a nice place where we can see people in person, but then also have the accessibility to be able to communicate with them at home and to monitor them at home. We've been working a lot with engineers over the past 10 years on trying to make technology more useful with this regard, with these goals that we have in mind. And one of the first studies that we did was a pilot trying to investigate whether wristband wearables could be useful in passive monitoring of subclinical atrial fibrillation. This was before the Apple Watch and some of the other devices received FDA clearance for being able to help risk stratify for atrial fibrillation. At this point, when we started this study, there was nothing out there. And so this was a really interesting and unique opportunity for us to be able to understand, is this possible to actually try to assess atrial fibrillation just from a watch without the ECG? And it's something that, it sounds a little bit implausible just because you really do need ECG for atrial fibrillation. So, but what we attempted to do is just to see what's feasible. So this really sort of big, and this is just kind of half the people I think involved with this study, but this group of people, including residents, engineers, and staff, we recruited 100 patients who were undergoing inpatient telemetry, and chose 50% people with atrial fibrillation and 50% people with normal rhythm. And we put a watch on them just for 5 minutes. We said, hey, we're trying to develop this new way to develop atrial fibrillation using a watch. And we were able to get raw data on the pulsatile waveforms. We actually were able to measure ECG with this particular device, looking at movement, and a lot of wavelengths that are important for oxygenation as well. And so this is a very busy slide that shows a little bit about what happened with some of the data. Anytime, it's amazing to take for granted what happens when you put on a smartwatch. There are a ton of data streams that are really being captured by these devices. And all we get on our screen is my heart rate and my steps. But beneath that, there really is a lot going on. And so just to show you here, we have every single pulse we have for a normal subject and a subject with atrial fibrillation. And then we also have the movement data, the raw movement data. These data were processed by the engineering team and then transformed into pictures that could be used in deep learning and convolutional neural networks for really trying to assess what is this person's underlying rhythm. This was a real challenge and continues to be a real challenge because a lot of movement can make these pulsatile wavelengths look like atrial fibrillation. They are very, very sensitive to noise. And so what we needed to do was we needed to integrate both the accelerometer data, the data from the movement, with the pulsatile data to try to rule out the false positives and really only try to get where is it that they really had atrial fibrillation. Was their wrist still? Looks like it. Okay, oh yeah, that looks like atrial fibrillation. So we had to program this algorithmically, and it was a real challenge. In one of our best attempts to do this, using leave one out cross-validation, we were able to get an area under the curve of 0.95 and an accuracy of 92%. There was another effort that we had where the engineers looked at data from bedside monitors with millions of data points, additionally to train these models with atrial fibrillation, and we were able to increase the accuracy to 95%. This still continues to be controversial and something that requires additional refinement as we think about some of the liabilities of false positives and how for a lot of consumer devices, there are a lot of people who do not have atrial fibrillation who are at risk of a false positive. We used the same device in the same cohort, and we looked at classification of heart failure as well. So as many of us are aware of, heart failure and atrial fibrillation are like peas in a pod. And so as we see that there are, in this cohort where we had a lot of people with atrial fibrillation, we also had a lot of people with heart failure. Approximately 40% of the people in this group had heart failure. So we looked at the same data, the movement data, the pulse data, and we asked, okay, well, do these data, trying to put them in a different machine learning algorithm, do these data help us to classify who has heart failure and who does not, and thinking about some kind of other application, a little bit more experimental in our approach, right? Because there are not a lot of clinical decision-making pathways in which the risk of heart failure on a watch has any clear relevance in our practice. But this is a proof of concept. And what we found was that the wearables by themselves were able to have some level of relevance in predicting heart failure. So this is model 1, which is just the wearables features. And you can see that in the red, that this is the area under the curve. This is pretty good. If we try to hold the sensitivity at 80%, the specificity was 53%. The positive predictive value was 0.7. If we added data from the chart, including their medical history and their demographics, these numbers did increase slightly. And so you can see here in the blue, this is including their chart data, and we were able to increase the sensitivity and specificity a little bit more there. So in addition to wristbands, we also carry phones, and as we showed in a previous slide, that the amount of people 65 and older, are a group in which there's the lowest amount of smartphone adoption, that there's about a 66% sort of prevalence of smartphones as of 2021, and we do expect this to increase. There is the possibility to really understand people's behaviors very, very well with the data from the smartphone. And Gary Clifford and I collaborated on a smartphone-based risk prediction study. It actually started many years ago, but maybe like 20 years ago with some of Gary's work in Oxford, in which they were using smartphone data for the purposes of mental health disease classification, in particular bipolar disorder, for example, looking at patterns, also schizophrenia, looking at patterns of movement, patterns of usage that include things like location, calls, how are people's behaviors and how do they change over time? So they found that it was very effective in looking at exacerbations in bipolar disorder. What we ventured to do was a one-off of that and looking at how this may help to classify heart failure. And what we had was a combination of data streams coming from this smartphone app that includes data on movement, also on socialization. We also did do surveys, KCCQ surveys or Kansas City Cardiomyopathy Questionnaire surveys about once a week to look at their quality of life in heart failure. And we also experimented with giving them a smartwatch as well. This is a very busy slide that goes into the different dimensions of this. We had called, Gary's group called this app AMOS, and it's otherwise now known as MOYO. So we ended up approaching and enrolling 28 participants with heart failure. We installed this app on their phones, and we performed chart review to understand what their health status was, trying to get the most data possible on when they were sick and when they were not sick. So every time someone came into the hospital, we would look at the assessment and plan of that encounter. Were they deemed to be compensated, euvolemic, doing fine, or were they thought to be decompensated? This could be an outpatient or inpatient clinical encounter, for example. Overall, with 28 people enrolled, for over a year, we were able to record 110 clinical encounters. And a lot of the data that were captured from the smartphone were passively captured and just uploaded to the cloud. We then performed machine learning and signal processing on the data. And then also considered, well, what happens when you look at both the data from their self-reported quality of life with the KCCQ and the data from the smartphone. And what we found was that, that we were able to just kind of, in a proof of concept graph here, we were able to really visually see a lot of differences between people. This is just an example, who had like a readmission in which there were low levels of activity before this, let's say, heart failure readmission, and then afterwards, after they were diuresed, they returned to regular activity. And this was a contrast to situations in which their levels of activity were the same before and after, let's say, a well visit. So this was the contrast that we were setting up. And this is data from a preprint. This is Aisha Chakmak is the first author. She's one of the graduates from Gary Clifford's lab. And what she found was really interesting, that in her machine learning algorithm, what we have listed here is a list of what we call features that were predictive of worsening or decompensated heart failure. And the red signifies high values of this feature, and the blue signifies low levels of the feature. And if it's further to the right, it has more of an influence on the model, in which it was associated with higher risk of decompensated heart failure. And If it's on the left side, then it's associated with lower risk of decompensated heart failure. So if it's further away from this line in the middle, that means that it had a stronger influence on the model in general. So for example, here, the call duration, right? So we weren't spying on, I know it looks like we were spying on people. What we did was we actually just collected metadata on their socialization. So it was like, okay, well, we just want to quantify how long your calls were. And what we found was that the length of these calls was actually really, really important influence on whether or not someone was sick in these models, such that the longer the calls, then the higher the readmission risk. And so this was actually one of the most important features. And we found that people with shorter calls typically were less likely to be in decompensated heart failure. The KCCQ score, the higher the KCCQ score, the higher their quality of life is for heart failure. And we found that, in this case, lower scores associated with worse risk of heart failure. The number of calls had the opposite association with the duration of calls. So if they were doing more calls and they were shorter, in general, that was associated with lower disease risk. If they were having less calls and they were longer, that was associated with higher disease risk. And then lastly, I'll talk about this before moving on. The standard deviation of their physical activity. So this is like how much variability they have in their physical activity was also an important marker. So the more variability in their physical activity, then the worse off they were in terms of heart failure risk, and the less variability in their physical activity, then the less heart failure risk. So, this is a lot of these data were pretty easy to come by because we could passively monitor this. The participants didn't really have to do anything, and so what we found was that we were able to get pretty decent results, especially if we combined the KCCQ score. What we found was that in our efforts to try to classify compensated and decompensated heart failure, that the accuracy was 77% if we included some of these kind of features on KCCQ, motion, and the social factors. Now I'm going to pivot to the ECG. So we were first talking about wristbands, we were talking about smartphones, and now I'd like to talk about ECG. ECG is something that's increasingly becoming available portably, as many of you probably know. A lot of now consumer-grade wristbands are offering a single-channel ECG, and there are products on the market that can also allow for multi-channel ECG. For example, with the AliveCore Cardia, we can get 6 frontal leads of ECG with that device. And so this really allows us to do a lot in the home setting with remote patient monitoring. I was really interested in some of the metadata that are printed, actually like printed on a lot of standard 12-lead ECGs that oftentimes don't necessarily get used in our clinical practice. So for example, a lot of these have established clinical cutoffs, but if people are within normal limits for a lot of things like PR interval, QT interval, things like that, that's typically not very clinically actionable. A lot of times we see PR and T axes that are off, but we don't necessarily take advantage of these and know what to do with the information. And so what I had set out to do was try to understand how is it that these might be useful in predicting cardiovascular disease death. And we had these data available to us actually in a publicly available data set from the National Health and Nutrition Examination Survey. So we actually had several cohorts that had ECG data, and 2 of the ones that I looked at were from the first and the third National Health and Nutrition Examination Survey. This initial cohort was recruited in 1971, actually, and then the NHANES 3 cohort was recruited in 1988. Because we had 2 different cohorts with different machines, slightly different populations, this offered a really nice opportunity to develop an algorithm and then to validate it in two completely different cohorts. And, and so what I set out to do was develop a risk score for fatal and non-fatal cardiovascular disease events just using data from the ECG. This includes the P, R, and T axes, the heart rate, and the PR, QRS, and QT intervals. These are all the ones that are automatically generated from the computer. So it doesn't really take a cardiologist necessarily, if you trust the computer, and I think that's a whole separate discussion. But at least kind of if we go off of what's automatically derived, then we set out to test how are these data useful in predicting prognosis. We added age and sex because those are really critical aspects of it, and we also explored race. So we derived a score in NHANES 1, and then we validated it in NHANES 3. What we found is that in NHANES 1, we found that by and large, age and sex were very important predictors. Race was not an important predictor in this model. There was an interaction between age and male sex that we also took into account. And then really there were three ECG variables that helped to explain cardiovascular disease events. The other ones did not really surface to the level of being worth including in the model. And these three were the T-axis, the heart rate, and the QT interval. I want to make special mention of the T-axis. It was a very powerful predictor. This is really the frontal T-axis. This is one in which what we found was almost like a V-shaped relationship with cardiovascular disease events, such that at a 45-degree angle for the frontal T-axis, we found that there was a nadir or a really low point of cardiovascular disease deaths. But as you deviated in one direction or another from the T-axis, that there was an increased risk observed in both directions of cardiovascular disease events. With heart rate, this was a dose-response relationship. The lower the heart rate, the lower the risk. These were people that were on the younger side, so we're not as worried about people with like sick sinus syndrome or bradycardia due to ischemic heart disease, inferior ischemic heart disease, for example. And then the same thing with corrected QT interval. There was a dose-response relationship. The higher the QT interval, the higher risk of outcomes. This is something where we did not use clinical cutoffs. We looked at these as continuous metrics, and we found that this gave us more predictive power to do that. So we received very good results when deriving this in NHANES 1. We then froze the model and applied it in NHANES 3. And what we found was that the results were pretty robust for ischemic heart disease death, cardiovascular disease death, and all-cause death. And the C statistic was 0.8, for example, with ischemic heart disease death, 0.79 for cardiovascular disease death, and 0.75 for all-cause death. If you compare this to the performance of what we typically use in our clinics for primary prevention, and these are people without cardiovascular disease, is that we actually get a similar result with the pooled cohort equation for ischemic heart disease death, and roughly similar result for cardiovascular disease death and for all-cause death, compared to just the ECG plus demographics alone. I was pretty awestruck by this and thinking, wow, it's pretty amazing how you can have data sources coming from two different pots. One is really focused on risk factors. Another one is focused on just data from the electrical signal of the heart, plus the sociodemographics. And you can get at the same place in terms of the predictive value in trying to predict 10-year outcomes. And so that to me was kind of surprising. There is this possibility in clinical practice to combine what we get from risk factors and what we get from ECG, and to see if that can move the needle. Can we get people into a more accurate category of their risk? Can we get people who die from cardiovascular disease into a higher category where we treat them more aggressively, and people who do not die, who survive, basically can get them in a lower risk category, give them more reassurance, pat them on the back. And what we found was that there was a pretty significant net reclassification index improvement of 25% for categorical outcomes. These are outcomes in which, or kind of categories in which there are decisions that one could make based on the outcomes. This was based on the European guidelines that focused on cardiovascular disease death and thinking about things like statin therapies. And then also the continuous net reclassification index was also really high. These numbers were similar to what a previously published study in JAMA showed with regards to calcium scores and how they improved categorical and continuous outcomes. This is perhaps just the tip of the iceberg in terms of what we could potentially do as we think about both clinically actionable and also subclinical data that could at some point become useful. We could think about portable ECG in terms of one channel, or nowadays we're able to get more than one channel with some of these devices. And whether we measure it manually or we have algorithmic approaches, things like resting heart rate variability, which is not something that's being used in the clinics, but a lot of consumer devices are using them for wellness. QT interval is something that obviously has a lot of clinical relevance in cardiology. This is something that we were really hungry to measure, especially during the pandemic when everything was shut down. We were trying to really avoid social contact. For a lot of our people on antiarrhythmics, we were really grappling with how do we do surveillance on their QT intervals and dose their antiarrhythmics accordingly. T-axis, as we talked about in the NHANES study, is really important and might be something that we use more. Obviously, arrhythmias are really important. We had talked about atrial fibrillation, and that's very, very, very clinically actionable. There are some data that show that QRS amplitudes are important, particularly, obviously, we're thinking about left ventricular hypertrophy. But the other thing that's interesting is that because the lungs provide some level of electrical cushion, if someone has heart failure, they have pulmonary edema, or if someone has even COVID pneumonia, that may influence the QRS amplitudes, and that's something worth exploring in terms of remote patient monitoring. As we think about ischemia and infarction, ST elevations, depressions, and Q waves are also things that we can also consider monitoring. So ultimately, there's this question about, okay, well, if we can get ECG and multi-channel ECG, what's the future there? Not to say that we have a lot of data right now, but I think that with research, we could potentially do more. A lot of this really becomes relevant as we think about cardiac rehabilitation, where there are a lot of resources being put into a single particular patient, and thinking about the number of visits, for example, with traditional cardiac rehabilitation. These are 3 visits a week where we do hands-on exercise, ECG monitoring with patients over 12 weeks. So really a lot of visits that we have with patients. So really a high-touch program, but also one that can really reduce cardiovascular disease deaths by 25%. Cardiac rehabilitation is more than just exercise, by the way. It is a comprehensive lifestyle change program following a cardiac event. And just where I practice in the VA, there's probably 20,000 veterans a year. And this includes heart failure, where the cost can be $30,000 a year just to manage that. Especially at the VA, we've had tremendous challenges with implementing cardiac rehabilitation. The hospital itself, even parking there is challenging. And so trying to run an exercise program, a hands-on exercise program, with a lot of our veterans being rural, coming from 1 to 2 hours away, was something that we were never really able to do. So we've at this point been contracting with, for example, Emory to be able to offer veterans services. But needless to say, with everything involved, we've had really hard time getting veterans into cardiac rehabilitation as we think about costs, travel, and also things like mental health and their health literacy. So several years ago, what we did was we invested some time and energy into virtual cardiac rehabilitation. We were desperate. I mean, we had a lot of people who were just not getting care, and as we saw that there's this inflection point in the utilization of mobile technologies, we took advantage of this tidal wave, so to speak. And we started playing around with these models that include technology for cardiac rehabilitation, that include exercise and behavior change at home. And in general, what I'm showing here is kind of what these sorts of programs in general look like, and then I'll talk about what we did. And so in general, when we think about trying to motivate behavioral change, right, this is a different story than what I presented before with regards to diagnostics. This is more behavioral sciences. We do have the option, the ability to engage patients to be able to use their phone as a diary, but also as a bit of a voice to remind them. This is something that I do take seriously. We get a ton of alerts, but there is still this possibility. Not everyone remembers what you tell them. So if you think about what's normal is that patients come to see us in clinic, we give them a little bit of advice and then they go home and we're not sure, well, what really stuck? You know, is this something where maybe they remembered 50% of what we said, maybe they remembered one sentence? With these technologies, we can offer them continuing education on their devices, even, for example, referring them to certain videos, different reading materials. So I think that just the smartphone itself and apps we put on there can be really helpful. Wearables and sensors, this is an emerging thing. This is something that has some relevance in home-based cardiac rehabilitation as it relates to activity tracking. How did you do this week? How many steps did you do? Things like that are not necessarily FDA approved, but can give us some data on how people are trending. A lot of patients have exercise prescriptions based on heart rate. There's some concern that if their heart rate goes too high, that they need to stop exercising, and it might even be subclinical. So the heart rate monitoring from these wearables could be helpful. Blood pressure, weight, these are fundamentals of monitoring. When people come into clinic, we get that one snapshot of what was their blood pressure in clinic, what was their weight in clinic. But what we don't see is what's happening at home. With connected devices, what we can do is we can really start to understand what's the variability, what's the range, what happens when you take out white coat hypertension, for example, and we're really thinking about ambulatory blood pressure. The guidelines have adapted now the importance of thinking about in-clinic versus home blood pressures differently when we think about treatment goals. So to be able to include this in cardiac rehabilitation is key. And then because this is a high-touch program in general, when you have a high-touch program, you do have resources for remote patient monitoring and to be able to do outreach when someone looks like they're falling through the cracks. In our program, what we do is we receive referrals from the cath lab, from the unit, from discharges, from MIs, and we give patients choices. We say, hey, you know, there's different ways to do cardiac rehabilitation. There's the traditional approach, going in and exercising in the hospital, and then there's the home-based approach with and without technology. A lot of veterans do choose the home-based approach with technology because, as we talked about, people do have smartphones these days, and they like the idea of having some kind of gadget. You know, it's kind of exciting for them to have some kind of wearable tracker and to be able to keep up. And so what we do is over 12 weeks, similar to what happens with a traditional cardiac rehabilitation program, is we do virtual visits. It could be every week. It could be spread out a little more. And we use motivational interviewing to try to nudge them towards increased exercise. We infuse a lot of education, some monitoring. They can alert us, for example, if they are having any issues at all. This can include sudden changes in heart rate and weight, for example, and then they can track what they do. And then at the end, we were able to do some more assessments. And so this is some schematic of the data flow where we get patient-generated health data from participants through their fitness tracker. They log their exercise sessions, and they do surveys. It could be every week, in addition to at the beginning and the end of the program. They can chat with the coach, log their smoking, for example. Some choose to do a smoking diary, and every time they smoke, they can log that. And then also their vitals. And then what we have the ability to do then is when things look awry, we get alerted on this dashboard and can call them as needed. But then also what we have is the ability to get the data in a table format that is what we think is clinically useful and actionable, and then put that into our notes in the electronic medical record system. And this helps for care coordination and billing. So, and this is another schematic of what the patient sees. So from the patient's perspective, they see the app. This is the Movin app that we use, and it has a lot of really simple graphics to be able to interface with patients. Really kind of big icons, for example. So even if there are issues with vision, for example, that it's friendly for patients to use. And then through this app, they can watch videos. There's a library of education content, but they're also able to interact with the coach. And the coach can also see their data on the dashboard. The team can also program in alerts for the patient as well to remind them to exercise and to take their medications and to log their information. So overall, the general idea is that the app and the way we program it can increase patient engagement. My friend and colleague Arash Arzand has worked really hard on this. He was the one that started this at the VA, probably 6 years ago. I'm showing some data from one of his presentations at American Heart Association, in which we had done some pre versus post analysis on about 100 patients who did 6-minute walk tests, for example. We found that overall there was about a 40-meter increase in the 6-minute walk distance. This is about what you'd consider clinically significant, and there's a statistically significant decline in the LDL cholesterol that we were not able to attribute to just changes in medication. Although what we do is we do spend a lot of time with the veterans going over medication adherence, giving them pill boxes, things like that. So needless to say, it's probably a combination of things that help their cholesterol. A number of other things changed. On average, they lost about 3 pounds. Some people had dramatic changes, losing like 20 pounds. We did not have a control group. This is just an observational study on an existing clinical program. But I think I do want to emphasize that in general, over time, people on average gain weight. So anytime we see, especially in this category, anytime we see a weight loss, this is going against the tide of what we typically expect for populations like this. Interestingly enough, we also saw changes in depression scores. The PHQ-9 score decreased on average from 7.4 to 6. This was something that I'm not showing these data exactly, but particularly in the people that used the technologies, their depression scores particularly decreased. Of note, what we're talking about is an average depression score that's about mild depression in this group. So it is something that, about 20% of people have moderate or higher depression, but on average, there's a range here. We did an analysis a couple years ago also looking at what's the 1-year event rate from people that do the different forms of cardiac rehabilitation. What we did was we looked at a cohort of people that were referred for cardiac rehabilitation. So they all had some kind of cardiac event, and then they were referred. We were not able to get everyone into cardiac rehabilitation. We were only able to get about 50% of people into cardiac rehabilitation for a number of reasons. This includes things like cost, includes things like they're losing interest, losing steam, or not being able to get a hold of them, or some sort of administrative issue. And what we found was that even when adjusting for anything that we could measure in the electronic medical record system, including their Charlson comorbidity score, different cardiovascular parameters like their ejection fraction, what we found was that in general, there was a lower hazard ratio for 1-year events, including hospitalization and death. This was statistically significant for this large group of people that did center-based, and the trends were very similar for home-based rehab and for smartphone-enabled rehab that uses the technology. It was not statistically significant at this small sample size, but this is something that is due for an update. Overall, the event rate was really, really low in the smartphone group. This was a slightly different group as we think about tech literacy, however. Lastly, I wanted to talk about some of the aspects that I think are really relevant for policymakers. Are these things potentially cost effective? I think that we don't have a ton of data from the United States on these questions. There have been a lot of interesting things in Europe, given that in Europe we have more single payer systems there, so it's really relevant there from a public health perspective to do these types of analyses. They're definitely ahead of the curve, and I think that a lot of them do see that, wow, you don't have to pay for the building, and you don't have to pay for a lot of these other things if you can go virtual. You can engage people for longer in a virtual setting. And so I wanted to just talk about the Telerehab 3 study, which was a multi-center randomized controlled trial in Belgium, and randomized people to traditional cardiac rehabilitation versus a 24-week hybrid program in which they started going remote at about 6 weeks, and then it sounds like did more remote visits after that. And they looked at both the cost of the interventions as well as clinical outcomes and quality-adjusted life years. And interestingly enough, in the hybrid cardiac rehab group, this was the one that received both sort of observed training, exercise training, as well as telemonitoring, that the costs were actually lower. 2,156 euros versus 2,720 for the traditional group that did 12 weeks of monitored exercise. With the difference, that's 564 euros. A euro is about $1 as of today. The hybrid group had an increase in quality of life in terms of the Euro 5QD scores versus a reduction in the control group. And in terms of hospitalizations, there was also a significant reduction in the number of days of hospitalizations in the hybrid group versus the traditional group. And so overall, there was a cost savings of 22,000 euros per QALY. Of note, typically when we think about preventive interventions, there's a cost for these interventions. In this case, it's negative, it's reversed. So for example, if you think about like dialysis, it's about $100,000 cost per QALY. Here, there's a negative $20,000 saved, in a sense, a $20,000 savings per QALY to do this kind of hybrid approach. So effectively, it's a no-brainer. It's a no-brainer, better health outcomes and reduced costs if you can pull it off. So overall, here's some key points. mHealth technologies, I think, do have the potential to help to fill gaps in cardiovascular disease prevention, especially when we think about the number of events that happen at homes that are catastrophic and that don't even allow us to intervene at the hospital. People die at home. We need to look at how can we consider subclinical changes in health status, how can we improve communication amongst the healthcare team and increase engagement for self-care. We do need a lot more research to bring these things into clinical practice and to improve our scientific rigor and also think about things like cost effectiveness. So how does this work in the US, which has a different payment model? And now that we have CPT codes and whatnot, all that needs to be analyzed to understand what's worthwhile and what's feasible for hospital systems and for clinics. There are a couple of studies that we have ongoing that I wanted to briefly mention. We have one here at the Emory Hospital called Prem Health, where we're looking at how are portable health technologies related to the smartphone app that I showed, but also a low-burden ECG patch. How can that be helpful in heart failure telemonitoring? There's one called Manage Heart Failure that we're also recruiting for that looks at, this is an NIH-funded study looking at apps that aim at education and sodium reduction in heart failure. And then our cardiac rehab program called Smart Heart as well, where we can do comparative effectiveness work at the VA with these sorts of technologies. Wanted to acknowledge several collaborators. This is a list that needs updating, but it goes on in terms of the number of people that have made this work possible. And I wanted to thank you for your time, and we have a little bit of time for questions.
Great, thank you so much, Amit. That was fantastic and a very nice overview of all the things you've been working on. I'm curious, your cardiac rehab program, was there a mental stress component to that virtually also?
Thank you so much for mentioning that. I'm very happy to say that we have a health psychologist on the team, and we offer every patient opportunities to see health psychology, and also learn things like meditation, for example, get cognitive behavioral therapy. This is something that we don't do without asking, but we do give every veteran an opportunity to opt in for that, and many of them do take advantage.
Great. Dr. Rab has a question. Go ahead and unmute.
Hi, good morning, and thanks for a great talk. So obviously, from my area of interest, where are we that if somebody has a VTAC or VFib on the Apple Watch, EMS can get activated pretty quickly to get to the individual?
Can you repeat that, Pooja? Yeah.
Can you hear that? Can you hear me?
I think what we heard is you're wondering about if somebody has VTAC or VFib, what can we do in terms of wearables now?
No, and where and how soon can EMS get activated or triggered to respond to that patient?
Something about how do we respond to patients who maybe who have ICDs, for example?
Or just,
I'll type it in. Okay.
okay. I think what he's saying is that if there's VTAC, VFib, and activation of EMS, is there something that mobile technologies can improve?
Yeah, I would say that that would be on the frontiers of where we could potentially go with this, because that is so time critical. That does take a lot of infrastructure building to get at products like that. I think that we're actually at a place much earlier on the disease spectrum where the hope is to prevent people from getting there. Obviously, that's really hard, but I think that unfortunately a lot of these are very kind of slow technologies, and so as it relates to what happens at the time of catastrophe, I do think that that's a limitation at this point, unfortunately.
Okay. Dr. Rab, you can type in your question if you, I think that's, oh. If you see VTAC or VFib on the watch, how far is technology now in activating EMS? Yeah, that's what you answered.
Oh, absolutely, yeah. So I would hope that those events are pretty rare, but needless to say, I think it's a good point. Most of the time, I would anticipate that this would not be a clinically silent event, that we would be able to do that. But ultimately, I think that brings to mind one very important point, which is that the watches don't actually passively, without intervention, monitor for arrhythmias. Someone has to stop what they're doing, touch their watch, and open up, for example, like the ECG app, and then close the loop. So for someone to be able to do that, typically they, especially for VFib, like they wouldn't be able to do it. Some could obviously have VTAC and slow VTAC and close the loop there. But typically, if they're with it enough to be able to check their own ECG, they could probably call EMS, I think, in a lot of cases. Needless to say, I think that safety feature is potentially relevant, but needs to happen very carefully because of the fact that noise and electromagnetic signals can cause false positives, and there's a lot of liability related to calling EMS if it's not truly VT, for example. So I think it's a really important question.
Great. So the use of wearables is going to just keep increasing. So do you think that having somebody who kind of, as patients see rhythms and things, they take pictures and they upload it into the portal and ask questions. So do you think it's worth having somebody who is kind of like the front line to answer these questions, in clinic, so that, just because as a group, everybody's probably getting messages daily, so
Yes.
maybe there should be somebody. What are your thoughts about that?
Yes, yes, absolutely. And you know, it's really unfortunate. I think as a healthcare system at the moment, outside of cardiac rehabilitation, I don't know that we're ready for the deluge of information. It's almost like kind of like this crowd building outside of a locked door, like, you know, trying to find entrance. There's so much information that people want to share, and they're trying to really kind of push it into this small door of the secure messaging systems that are available to them, trying to get their images in there. But unfortunately, I think in a lot of cases, probably most, it exceeds the capacity of the healthcare system to be able to effectively manage this. And so what we do need are other affiliate providers who can handle this information. And I think this is where the CPT codes for remote patient monitoring can be useful. So if we could pay for these affiliate providers with certain codes that are new, then we could potentially create a sustainable system.
Great. Dr. Taylor has a question. Very interesting talk. A real issue with these remote approaches is scale. Your rehab approach involves coaches and individuals to respond to the data. As a specific question, what sort of staffing ratios would be needed to manage the large number of heart failure patients that we follow?
Absolutely. And I think once again, this is something where I think that things like cost effectiveness, things like, you know, what does it take in terms of someone's daily routine, in terms of what, let's say, revenue they're able to generate to sustain a practice in which there are a certain number of participants that someone is monitoring, that they do a certain number of telemonitoring kind of encounters, so to speak, and can bill for it. I think it is to be determined in terms of what that optimal ratio is. To a certain extent, it is determined by just, you know, if we try to think about a healthcare system as trying to be cost neutral, it will come down to some of these very real elements of kind of what's possible. But the hope is that there is some level of sweet spot that the technician, for example, or the nurse themselves is not overburdened by the amount of volume that they see.
Great. Dr. Raab has a question. Will smartwatches replace the event monitor?
So no, I think that right now, because the event monitor does ECG level monitoring without any intervention in itself, without any kind of active patient approach, whereas the smartwatches do require the patient or the participant to close the loop and to only measure and only able to measure things in 30-second snippets. It will not replace it, especially for indications like syncope, for example, or as we're thinking about subclinical AFib that can happen at any time of the day. It's not going to quite get there. AFib, it's, you know, I think that we are getting closer and closer, but once again, without ECG, I think it's going to be really hard.
Great. Raj says, great talk, Amit, but I'm biased, obviously. And then there's the question from Dr. McCunnan. Thank you for your talk, Dr. Shah. I wonder, are there efforts from private companies such as MyFitnessPal or Noom partnering with the VA or health systems to assist with behavioral change in terms of nutritional physical activity?
Absolutely. I think there's an entire innovation ecosystem at the VA that works with a lot of companies to sort of try to sort of test, examine what is possible with regards to this very large healthcare system that's focused on prevention. And I think that you know, there are a lot of ongoing discussions. Those particular ones that were cited, I have not heard those. I've not heard of those sorts of discussions. Arash, he's a senior innovation fellow at the VA, works a lot with the national team, and he's actually, I'm going to put him on the spot. He is probably one of the best references as it relates to you know, what are some of the activities on the cutting edge at the VA.
Great. If there are no other questions or comments, we are a little past 8:30, so in the interest of time, I'm going to go ahead and close this. Thank you again, Amit. That was fantastic. And thank you, everyone, for joining. Don't forget to get your CME credit, and I will see you in the fall. Thank you, and have a nice summer.
The preceding program is copyrighted by Emory University.